Hi, I'm Jean-Luc Tilly, a program director here at Leapfrog, and I'm joined today by a couple of experts at Shore Medical Center. Dr. Jacoby and Kris, could you introduce yourselves and tell us a little bit about your role at Shore Medical?
Hi, my name is Kris Liwoch, and I've worked here at Shore Medical Center for almost 40 years. I am the senior analyst for the organization, and I am also a Leapfrog certified coach.
Thanks, Kris. Hi, my name is Dr. Dan Jacoby. I serve as the Director of Hospital Medicine for Shore Physicians Group and also the Division Chief of Internal Medicine at Shore Medical Center.
All right, terrific. Thanks to you both for doing this. Um, So I'm hoping today we can talk about Leapfrog's Recognized Leader Program, and congratulations again on your achieving that award last year. And I was hoping maybe just to kick us off, you could tell us a little bit about how you came across the program and what interested you. What led you to apply for the designation.
So we've been participating in the Leapfrog survey for approximately, I would say, 20 years now almost. And we also saw, when you're doing your survey, there's on the website, you see advertisement or acknowledgement for the Leapfrog diabetic survey and recognition. Being that we're always looking to improve and we love serving our community and our patients, we looked into that and we're very interested in seeing how to go about achieving this recognition. Our first year, when we first saw it, we had to step back. We really needed to do a comprehensive gap analysis to assess where we are, where we needed to be, and then using that, we made our project plan to move forward. So we achieved it after that.
Terrific. I guess I'm wondering actually about what you just described. That first moment we were just kind of reviewing the requirements and thinking about how that compared to your current state. I mean, can you tell me a little bit about that? That process and how you first felt when you were sort of comparing the requirements with your business as usual.
We had to verify that we had the diabetic educator. We had to do a lot of education. We actually brought a whole multidisciplinary group together, which I think is a very important part of our process, aside of the gap analysis, because you get every aspect of the survey and of the requirements all in the same room. And once you get that free speech flowing with each other, you kind of realize, and what we realized actually is that we were doing more than we thought we were doing. We just didn't put all the building blocks together or the puzzle pieces together to make them fit. So I would say the multidisciplinary meeting was paramount in us achieving this recognition.
Terrific. And now I'm wondering, I mean, it sounds like there was a big effort to kind of get, to put together those internal resources to kind of get folks together. And I guess I'm wondering maybe if you could speak a little bit to, how long it took to put that core team together and how far back you started planning and then just, to give a sense of the timeline for bringing this all together.
So when we first looked at it, I believe it was back in 2023, our diabetic educator was part-time. So right there, a change needed to happen and an improvement of care needed to happen. So from 2023, for about 6, 7 months, we started putting the pieces together. Once we were at that stage and we had that initial meeting, our next step was actually pulling all the policies and procedures that we actually already had. And I would say there was about 30 of them that we had to adjust, but not create. We didn't have to create any policies. So the whole process, because it did impact our providers and every aspect of the organization, I would say took about 8 or 9 months to really pull it together and to be comfortable in our new protocols, processes, and policies. And we also had to get buy-in from our nursing leaders and our executives staff. We had to get an executive sponsor, which Dr. Galler is our CMO. And, you know, it really wasn't that hard because, again, our culture here at Shore Medical Center is doing whatever we can to improve patient care and follow best practices. So I would say the process took 8 or 9 months to get it fully implemented and submit.
Yeah, that's great. That makes sense. I'm wondering, you know, what one thing that we always hope for when we, add a standard to the hospital survey, creating a program like this is to, give you an opportunity to take a look at your own internal processes and even identify things that might be surprising or that sort of offers a little bit of a break from, your day to day to sort of step outside and take a look at new or interesting things. And I guess I'm wondering, when you're thinking about the different quality of care elements that are presented in the application, I mean, were there any that you found particularly challenging to implement or surprising or maybe unexpected roadblocks or even things that went really well right away and in a way that was encouraging?
We found when we were pulling the data that 27% of our patients were either pre-existing diabetics or newly diagnosed diabetics, which that was surprising. You don't realize how many are, you know, living with diabetes until you're really looking at the numbers. So that really was something to look at. We didn't see any disparities or because we pulled the data in every single way to look at it to see where exactly our opportunities were and if there were any additional opportunities. Because aside of just achieving this recognition, we wanted to look at the whole process and how we can improve across the board, within our walls and outside to our community. So I would say that was one of the things I found surprising. One of the things I'd love to give kudos to Shore Medical Center and its culture is we pulled in for our multidisciplinary team. We pulled in dietitians, nursing staff, and nursing leaders because we wanted to give everybody a voice. We had medical provider representatives, surgical provider representatives. We had executive team members. We had our pharmacists in there. We had our educators in there, our diabetic educators, our social workers and our caseworkers, because you have to prepare for, patients to be discharged safely. And what was really great was everybody got together. Everybody was excited about the program. There was no concerns about, any of the new initiatives we were going to put in place. So we really worked collaboratively and to get this done. And it just only shows what the culture here is at Shore, which I'm very proud of. Dr. Jacoby, do you have anything to add?
Yeah, I was just going to say, one of the things I think that stood out for us and would be helpful for other programs to know is that when we first heard about the certification and we sat down and looked at it at a very high level, we realized how much of this work we were already doing, and that our community might not be aware of, what services and how great our outcomes really are for diabetic care. Within Atlantic County, South Jersey, about 11% of the total population is diabetic. And like Kris said, almost a quarter of the people that are coming into our hospital are living with diabetes or being newly diagnosed. So when we saw that level of impact, that's what we really were surprised and pleasantly surprised about, because we started going through all the data points and everything that the the certification was looking for, and we were like, this is great. We're doing a lot of these things. There were some areas that we, were able to look at and to really ramp up more. But we saw this as a great opportunity just to let the community know what we're already doing and how great our outcomes really already are. One example that, something that we were able to ramp up with, and Kris can jump in here, was when we looked at our perioperative A1Cs and screening diabetic patients to make sure they're ready for surgery. And Kris, you can talk to that a little bit.
So when we looked at that, we found that our orthopedic surgeons were already doing this. So we already had a best practice in place that was working. So to push it out to all the surgical patients, and what's good for the inpatients, we also felt was good for the outpatients, because they're all our patients, whether they're going to stay the night or whether they're coming in for like a same-day surgery or ER visit or whatnot. So we pushed that out to inpatients and outpatients for everybody who had an A1C who didn't have an A1C recorded within 3 months. But it was really great because, again, like Dr. Jacoby said, we already had this process in place. We already were doing it. We just needed to spread it out amongst all the patients as opposed to just our orthopedic patients. And what we do is, when we do see an A1C that's concerning or that could put the patient at a higher risk for complication, we don't cancel their surgeries. We don't even use that word. We use the word defer. We defer their surgeries. We get them with our educators, with medical follow-up with a provider, and we get them in a good place. So then when they do come in and have their surgery, they're in a good place with less risk of complications or skin breakdown, and a better healing and a quicker healing time, actually.
Yeah, that's great to hear. And that's something it was one of the elements that we really went in depth with our expert panel, was about, surgeries and sort of the potential unintended consequences of that that blood glucose monitoring. And it's great to hear kind of reframe around, it's not canceled, it's deferred. I think that's really important. I think that really speaks to, thinking about the patient's experience, how the patient is experiencing that lead up to their surgery, which can be, as we know, such a stressful time. And it's interesting too to hear so much about, just the proportion of, the patients that you have in your hospital that are newly diagnosed with diabetes or living with diabetes. I'll tell you that at Leapfrog, when we first were meeting with the American Diabetes Association, thinking about the program, um, we really were thinking, it's a very condition specific. It's we're talking about, in a way, what we at first had thought maybe was kind of a limited set of practices. But then, as we learn more, as I got educated, we realized that so many of these facets that we're talking about here touch such a huge proportion of patients, and just sort of patients in general, right? A lot of these practices are good practices for everyone, not just people with diabetes. So that's a really interesting
Well, I
insight.
myself was living with diabetes and I did not know it. So
Hmm.
I was one of those that got the A1C and found out, that I had diabetes. And, it was a blessing. It was a blessing for me. I think for our community, for our family, for each other, that we actually do this because it puts the patient in a better place. One thing I would like to point out too, if we could just roll back to another part of what we did to actually achieve the recognition, is we had to evaluate our EMR. We had to make changes. So IT was involved to help make the changes, and we had to work collaboratively with them, nursing, care management, nutrition services, our dietitians, to put the power plans together and update any power plans to follow our policy and processes, and to help the flow of the protocol, because we didn't want to put any extra burden on our clinical staff. We like them to be able to spend time with our patients, not in a computer. So that was one of the challenges that we encountered. But again, we met no resistance in making these updates, and our EMR now complements the flow to follow our policies and protocols for diabetes.
Yeah, that's really interesting. I mean, that's been such an area of focus for us for some time now. I was thinking about the EMR and then, what happens next with that too, right? Something Leapfrog's starting to think about is, all the different kinds of applications that are going to come out of electronic medical records, in AI and other kinds of areas like that. So, um, it's good to hear that you got that clinician first mindset in terms of the some of the implementation of those new features. I think that's really helpful. Well, thinking again about the patient's experience, something that really came through from our expert panel, which I had a couple, people living with diabetes on it who had, been hospitalized because of their condition, had a lot to offer in terms of their um, the recommendations for performance measures. And something they really stressed to us was just the importance of educating people with diabetes, especially people with diabetes that find themselves, and as you'd experience yourself, as many do, getting diagnosed for the first time in the four walls of the hospital, sometimes because of having experienced a pretty serious adverse event. And I guess I wonder maybe if you could speak a little bit to your diabetes education for patients and maybe some of the value you've found there.
I'll start, and then Dr. Jacoby, you want to complement what I say? So we do have diabetes educators. Now we have two. We had to actually ramp up our diabetes education because of the program, which is really great. It just shows that it's working. But we also had to educate our nurses, our bedside staff, our pharmacists, and all work together to give the complete education to the patient. I have to say that it is a positive patient experience. When you are admitted to a hospital, you lose a lot of your independence. And especially, that's kind of alarming. Most people are used to doing things on their own. They want to do things on their own. So with the new protocols coming that we have implemented, a patient who comes in who has a insulin pump and they are monitoring their insulin pump, and that's not the reason why they're here, now they can continue to do that. It gives them back a little bit of their independence. It gives them back a little control of their care, which is a very positive experience for the patients to have some of their independence back. So I believe that was one of the positive things. Dr. Jacoby, you have anything to add about education?
Yeah, we learned that looking at this process, it really gave us, I mean, this might seem common sense, but how much of diabetes management is on the patient, and how much they need to be aware and an active participant in managing and treating their condition. So like Kris said, we definitely ramped up our educational offerings. We worked with our inpatient diabetic team, and I should mention that we have a dedicated diabetes care team. That care team incorporates a lot of the people Kris has already mentioned, but really the leader of that team is Althea Duna. She's a nurse practitioner. She specializes in diabetes care. She works with our outpatient endocrinologist, but she sees the vast majority of patients that are in the hospital for diabetic related issues. And with her leadership and guidance, we're able to create individualized discharge plans for each patient. We actually, create a document that isn't just a bunch of check boxes. It's literally, dear Mr. Smith, you were in the hospital for your diabetes, your A1C was this. This is what we want you to do. And we'll spell out their insulin regimen, their oral antiglycemics, their diet plan, their exercise plan, and then also like the what to do if situations. So it's really, really tailored because when we looked at what we were doing, And it's been my experience overall for a lot of medical conditions. It's very easy to give patients discharge information that's very generic. You were hospitalized for heart condition, and here's one of the 5 things it might have been and read about it. But we learned that, with the complexity of diabetes, you really need to give individualized care plans. So that's something that we've been doing now, and it's been working really great. And it opened up other opportunities too, for other programs to learn. At first, we realized we were literally just writing out instructions on a computer, printing them out, and handing it to the patient. Then we worked with IT and with HIMSS, our health, record department, to create more formalized, letterhead and, make it look a little bit more official and things like that. But that was something else that we learned to grow with. But yeah, the patients love it. They show up in their outpatient appointments with it in their hands. They hand it to their primary care doctor and they said, this is what they wanted me to do. So they're really engaging with it, and it's been a great tool.
Another thing to point out that we do, because like Dr. Jacoby said, our patients, they go home, they transition, and they have to continue to care for their diabetes and their illness, whatever illnesses they have, is we screen every patient for health-related social needs. And what that means is we find out if there's any gaps, underlying gaps for any other needs. Can they get food? Do they have available food to them? Can they afford their medications? Do they have transportation to get to their follow-up appointments? So we want to set them all up before they leave to make sure that they have all the pieces in place to be able to manage diabetes, or actually, as Dr. Jacoby said, it kind of expanded out to, all patients, and preparing all patients to leave. So when we screen them, we have connections with community resources to help the underinsured or the uninsured, and to get private education sessions. We actually offer community education to our community now, free diabetic education by Althea or one of our providers. So doing that helps us take care of not only the actual medical diagnosis, but the social needs and requirements that the patient needs to be successful once they leave our organization.
And one thing I'll add there as well. So part of the screening of the social determinants of health really helps us identify patients that are at high risk for readmission. Diabetes doesn't take a break throughout the day. It's 24/7. So one of the things we realized was that you can give a patient a prescription for new insulin or, oral medications, but they need that in their hands within hours of discharge. So, some patients have that community support or the personal resources to get themselves right to a pharmacy after discharge. Some people don't, and that's why they're here in the first place. So we've partnered with most of the manufacturers and pharmaceutical companies of insulins and other medications, the CGM monitors. We have a charitable donation of those devices, a stock in our diabetes department, so that when we identify patients that aren't going to be able to get that stuff quickly, we can actually send it home with them, so that they have a startup supply. They've got the glucose monitor. We even developed kind of a protocol to most of these CGM monitors now interface with your smartphone. So we even have a tech protocol to help them install it while they're in the hospital, get the app on their phone, and start seeing their glucose even in the hospital. We don't use that necessarily for like the official medical record while they're in house, but so that they can see, like, I just ate a meal. This is what it does to my sugar. Oh, I just took 8 units of insulin. Look at it go down. So they start to get comfortable with all that stuff. But it's such a unique, condition, because it's not just like, having high blood pressure where you take a pill once a day. So it's really an active thing. So we work with all that, and those partnerships have been really beneficial. And, I would encourage, other programs to look into the community resources. Almost all the pharmaceutical companies, have programs where, they'll supply you with, a small stock of medications to help patients in need.
No, that's great to hear. I mean, that's something else where with the expert panel, yeah, as you know, our standard for the discharge process is fairly involved. I mean, we're asking for I think about 14 different elements, but so many of them are covered by exactly what you just said. And it really is sort of running through all those different um, pieces of education and providing supplies, making connections to our other providers for the patient that really make for that successful discharge. So it's great to hear that you're able to make that happen and able to expand it even in other areas that aren't covered by our standard. Because I think those all sound really, really worthwhile, especially in avoiding readmissions, which can be so costly. Um, well, I guess I wonder, from Leapfrog's perspective, from patient safety, we're often thinking about, continuous quality improvement. And I guess I wonder, just sort of, more generally speaking, what's next for your diabetes program? How are you thinking about the future here?
So, well, we're going to obviously continue with this program. More community outreach would be something that, we would like to expand upon. We also want to, we track and make sure, as with any new processes and new habits, it takes about a year, 2 years to really get the motors running perfect. So we still monitor and look for opportunities. We also, and Dr. Jacoby probably can speak to this more, medical is medicine is changing. It changes every day. I mean, first it was you get insulin, then you get a pill, and now we have all these new medications out for diabetes. And with that, they have to be taught on how to use them, how to dispose of them. So, we have to maintain and stay up on the latest and the greatest best practices as things evolve, because medicine is ever changing. Dr. Jacoby?
Yeah, absolutely. I mean, continuing education for even for our providers, our physicians, like Kris said, I mean, the evolution of pharmacologic treatment of diabetes in the last 10, 15 years has been dramatic. Um, so that's something that we're looking at. We partner with several of the larger university hospitals in the area to provide CME, particularly diabetes education. Shore Physicians Group, which is the physician group with Shore Medical Center, we just maybe 2 months ago had a speaker into our group meeting on the GLT inhibitors and all the new classes of diabetic medications and how they impact treatment and, what does a surgeon need to be looking out for with these new medications? What's an orthopod need to know? Because a lot of the time, specialties that aren't focused on metabolic medicine, they need to understand how, patients showing up on a new class of medications needs to be managed, so all of that continuing education is going to be something that we look to grow into. One of the big successes that we learned, throughout this process in the past too, was having a dedicated diabetes clinical team, a team that really is, focused on this management. We had a lot of success using the nurse practitioner model with oversight by the board certified endocrinologists because endocrinology is a much bigger field than just diabetes. Within the hospital, though, the vast majority of endocrinology work is diabetic. So we were able, really, from a resource perspective, rather than having a team of physician endocrinologists running around the hospital just focusing on diabetes, we've leveraged the nurse practitioner role, and it really has great outcomes for patients. So that's data that we continue to track as well. Just from a resource allocation perspective, the division of labor there has been really great. Our endocrinologists can spend 95% of their time in the outpatient office, managing these cases long term, making long term recommendations, et cetera. And then, having the nurse practitioners inpatient and, doing the bulk of the bedside care. It's been a really successful model.
That's outstanding. Thanks for sharing that. Well, and actually, I wonder along the same lines. Maybe this has been so great so far, but I wonder. I mean, um, to conclude, I mean, is there advice or recommendations or other kinds of words of encouragement or wisdom you'd offer to hospitals who are interested in starting this journey to attaining the recognition or just sort of focusing on diabetes?
Well, I find our comprehensive gap analysis was a good first step. So then when we presented what we wanted to do to achieve this recognition, we had a clear picture of where we were and where we wanted to go. I also highly recommend a multidisciplinary team. You can't make a change in one area of a hospital. One area, as you know, one area's change affects the whole organization. We had IT, we had nutrition, we had pharmacy, we had surgeons, we had medical providers, we had executive team, we had nursing, we had clinical educators. It takes the whole gang to really make things happen and to really connect the dots to make the process a success. So I would highly encourage that. I also would encourage to stay engaged, to stay focused, and to monitor what's up and coming and, the changes in medicine as they come along. Most hospitals are probably doing a lot more than they really think that they are, which is something that we found out. So that would be my recommendation.
Yeah, I would add on to say that just do it. They're a lot of times certifications like this might seem like a tall mountain to climb, but we're all about data-driven decisions. And when we sat down and ran the data, we saw how close we were, and we see the benefit of the program.
Mhm.
Um, how it impacts our clinical workflows and our patient outcomes. It was just great to bring everybody together and to really just show the community that we have a focus on diabetes. I mean, when you have a quarter of the patients that you're taking care of being affected by a disease, obtaining a certification that shows that you're a center of excellence for that is really, really impactful across so many different domains. I mean, Kris listed all the people. I mean, we even had our facilities department engaged in the process when we were looking at our insulin storage fridges and things like that. So, I mean, I don't know that there was a single department in the hospital that wasn't, impacted by the certification or contributed to the certification. So, um, it was really a good process. And, everything that we had, I mean, Kris deals with most of our back and forth with Leapfrog, but, the process was really, it was not burdensome. We were able to move through all the steps and achieve the certification.
It was actually exciting because we knew that we were making it better for our patients. We knew our care was improving, and that's what we do here. So it kind of was like very exciting and energizing to take this on and to actually accomplish it. And we plan to maintain it and grow.
Well, thank you both so much. Well, for the time and effort you put into achieving the recognition in the first place, but in taking the time with me today to share your experience and so many kind of concrete things to hang on to for other hospitals who might be interested in pursuing this. So I think it'll honestly be immensely helpful. Thanks so much to you both.
Thank you very much for having us.